We'll talk about ECG in children. And in case of ECG in children, we'll just see 3 or 4 ECGs very specific of either any syndrome or any specific arrhythmia we are talking about. We'll not be covering bradycardia or bradyarrhythmias or all the tachyarrhythmias. We'll just see one tachyarrhythmia and we'll see one cause of myocardial ischemia in children and 2 syndromes and what can be the specific ECG in those disorders, right? So let us start with our first ECG of the day. So can you see this? The first thing that what strikes us is the tachycardia. See, this is the RR. So there is tachycardia, there is regular rhythm. So regular rhythm, tachycardia, along with there is presence of P wave. So the most common cause of arrhythmia in children is nothing but supraventricular tachycardia. So here we can just see it's a narrow complex tachycardia, that is the QRS is narrow, less than 0.09, and it is a tachycardia with a regular rhythm with presence of P wave. So it is nothing but paroxysmal supraventricular tachycardia. So the diagnosis is PSVT. So let us write down the salient points. Most common arrhythmia that is encountered in children is SVT. A very gross way of differentiating between SVT and VT is the QRS complex. If we are having a narrow complex tachycardia, it is usually supraventricular in origin. Okay, so narrow complex is supraventricular in origin. What you get in PSVT? It is a narrow complex tachyarrhythmia with regular rhythm, presence of P waves. It is slightly more common in females in children, and whenever you encounter a PSVT, the first thing you try is the vagal maneuvers. So initial management include vagal maneuvers. It can include unilateral carotid massage, eyeball massage, even you place a ice pack on the forehead. Next, you need to see whether the child is hemodynamically stable or not. In case of hemodynamically stable, the drug that you can give is adenosine. It's 0.1 milligram per kg and then you can increase it to 0.2 milligram per kg. If you need to give a repeat dose. Remember, adenosine is always given in a vein that is close to the heart. We usually prefer the antecubital vein and we insert a bivay. Through one we give adenosine and with the other we give a 5 ml NS because the half-life of the adenosine is very short, okay, and it aborts the supraventricular tachyarrhythmia and it's reverted back to NSR, that is normal sinus rhythm. In case of hemodynamically unstable, we go for synchronized cardioversion, again we start with 0.1 joules per kg and we can increase to 0.2 joules per kg. So revising it once more. So most common arrhythmia in children is SVT. It's a narrow complex